Hi, welcome to the Nevada Joint Union High School District Head Injury Protocol, the role of the coach. So the agenda for this class, we're going to give general concussion information. Um, we're going to go over the evaluation form. This step is very, very important. We're going to go over the return to play steps and communication and also physician clearance. The objectives for this class include understanding the basic definition of concussion, recognizing signs and symptoms of concussion in athletes, understanding what to do if an athlete sustains a suspected concussion, and understanding the precautions, treatment, and return to play concerns for the concussed athlete. So here is a quick little session for anatomy of the brain. The brain is surrounded by fluid and protective membranes, which are called meninges, which normally cushion the brain. The brain floats within fluid inside the skull that has ridges and shelf-like areas, which is why it is vulnerable to jarring, hits, or whiplash-type actions. During an impact, the brain is pushed against the inside of the skull, which can be bruised. There is very little space for anything to happen in this cavity, and it may be even only a few millimeters of space. Most vulnerable parts of the brain to experience a concussion are frontal and temporal lobes. The frontal lobe, which is the largest lobe of the brain, is located in the front of the head. The frontal lobe is involved in personality characteristics, decision making, and movement. Recognition of smells usually involves as part of the frontal lobe as well. The frontal lobe contains Broca's area, which is associated with speech ability. The temporal lobe is responsible for auditory processing, short term memory, mood regulation, speech, musical rhythm, and some degree of smell recognition. The word concussion literally translates from Latin to English to mean to shake violently. Think about your brain as like an egg yolk inside of a shell. When the eggshell moves, the yolk is going to move inside the shell, and that movement of the brain inside the skull is actually what produces the concussion. You don't need to lose consciousness to have this injury. You don't even need to be hit in the head to have this injury. What is a concussion? A concussion is a brain injury that changes how the cells in the brain normally work. It is a functional, not a structural injury. All concussions are serious. Signs and symptoms can appear or worsen up to 48 hours after the injury. Generally, there is no loss of consciousness. Most concussions have normal CAT scans as well. There's no fractures or no brain bleeds present. To recognize a suspected head injury. There's two criterias. The first one is a mechanism of injury is seen or highly suspected, which is a forceful blow to the head or body that results in rapid movement of the head, or a sudden deceleration that results in rapid movement of the head, or any change in the athlete's behavior, thinking, or physical functioning. And then please see the signs and symptoms checklist and mental status evaluation after this to know the signs and symptoms. But if you do notice anything that is different, ask the student questions. So the causes of concussion is a blow to the head or body, a fall, especially falling back and hitting the back of the head on the turf or floor, a collision that causes the brain to move rapidly inside the skull, and a rapid deceleration without a collision. The magnitude of the injury does not always relate to the degree of injury and the recovery time. So there are a certain type of worst injuries that they have, and they're called coup and contra coup, and it's shaking forward and backward with no blow to the head. Immediate signs and symptoms of concussion include headache, confusion, dizziness, loss of consciousness, cognitive problems, difficulty remembering, blurred vision, nausea, vomiting, lightheadedness, balance disturbance, difficulty concentrating, and sensitivity to light or noise. So, knowing your role as a coach is knowing the signs and symptoms of a suspected head injury, know how to do the steps of the protocol, and how to recognize and report. The head injury evaluation form is a heart of the protocol for coaches. It helps identify possible head injuries with possible signs and symptoms checklist. It communicates with the parents. It expedites the process. And the backside of the form is for physician orders and has all specific wording required by the state included. So here is when you seek medical attention or call EMS if a loss of consciousness happens, appears drowsy, difficult to awaken, bleeding or clear fluid from the ears or nose, convulsions or seizures, severe neck pain, weakness or inability to move one or more limbs, severe headache, slurring of speech, unequal or dilated pupils or non-reactive to light changes, vomiting, sudden change in behaviors, and initial improvement followed by worsening symptoms. Here is what to do when you're calling 911. Call the EMS, you say medical and give location, give the age of the child and description of symptoms and what happened. You notify parent 911 has been called. You clear students or viewers from the area. You have a coach or student flag the ambulance down for a location. You fill out an incident report and you email the nurse's office. Why is it important to recognize a suspected concussion as soon as possible? Athletes are high risk for concussions both in and out of their sport. Complications and recovery time increases the longer a concussion goes untreated or unrecognized. Short term and long term consequences if not treated early, which is on the next slide. And concussions can affect students' learning, health, and social emotional functioning as well. So it's good to note that athletes are high risk for head injuries both in and out of their sports. They're risk takers on the field and off, so more concussions occur to students outside of their school sports rather than in school sports. They're very active and competitive. Complications and recovery time increase the longer a concussion goes unrecognized or untreated, and many athletes underreport and return to sports before fully recovered. Consequences of unrecognized concussion. Short term consequences consist of difficulty focusing, which leads to decreased academic performances, emotional lability, depression, disrupted sleep, and at greater risk for further injuries. Long term consequences of untreated concussions consist of post concussion syndrome, learning disabilities, which is processing difficulties, stuttering, focusing issues, etc., mental health issues, neurological issues, and CTE, which is chronic traumatic encephalopathy. Delayed signs and symptoms include irregular sleep patterns, fatigue or lethargy, depression, personality changes, and inability to perform usual daily activities. What is CTE? Chronic traumatic encephalopathy. Chronic traumatic encephalopathy is a brain disorder likely caused by repeated head injuries. It causes the death of nerve cells in the brain, known as degeneration. CTE gets worse over time. The only way to definitively diagnose CTE is after death during an autopsy of the brain. Symptoms include cognitive impairment, behavioral, mood disorders, and motor symptoms. Some cognitive impairments include trouble thinking, memory loss, problems with planning, organization, and carrying out tasks. Behavioral include impulsive behaviors or aggression. Mood disorders include depression or apathy, emotional instability, substance misuse, and suicidal thoughts or behaviors. Motor symptoms include problem with walking balance, Parkinsonism, shaking, slow movements, and trouble with speech. Motor neuron disease destroys cells that control walking, speaking, swallowing, and breathing. Second impact syndrome. This occurs when the brain swells rapidly after a person suffers a second concussion before symptoms from an earlier concussion have subsided. The second blow may occur minutes, days, or weeks after an initial concussion, and even the mildest grade of concussion can lead to second impact syndrome. It can be fatal or cause severe brain damage. Approximately 18% of identified high school brain injury deaths were preceded by an earlier concussion, which might have led to second impact syndrome. Concussion management. The cornerstone of concussion management is physical and cognitive rest until symptoms resolve. Activities that require concentration and attention, such as schoolwork, computer use, text messaging, etc., and physical exertion, sports, weightlifting, PE, class, etc., may increase symptoms and delay recovery. Here's the information about the head injury binder. So you check out a binder at the start of your season. Binders will be in the front office box. Binders must be at every practice and competition. Binders must be returned at the end of the season. Only trained NJUHSD staff may complete the forms, and student athletic trainers may not complete the form. Health technicians have the binders, which need to be returned back in at the end of the season to be updated. You save the parent time and money by always having this binder at all practices and games. Without the district specific forms, the student often ends up with orders from the physician that do not meet the district's clearance criteria. This often necessitates another doctor's visit. Many kids go to the ER and return with discharge paperwork that does not have what we need on it. If they have the ER physician fill out our paperwork, all of the wording is there. Also, the ER tends to undertreat concussions because their priority is ruling out life threatening injuries such as brain bleeds and fractures, which, as we know, might not be there with concussions yet. All concussions are serious and can lead to second impact syndrome. Here's some information about the coach head injury evaluation form. Remove student from activity immediately if a mechanism of injury is noted and other signs and symptoms of a head injury are suspected. So, the purpose of this is to provide a tool for school staff to evaluate a suspected head injury. It ensures parent is contacted and it provides a diagnosis from physician if student has or does not have a concussion. This form must be completed if an athlete has a suspected head injury. The step is very, very important. As we went over before, please make sure you do this simple step. It really makes a difference. The front of the form has signs and symptoms of a concussion, signs and symptoms that warrant immediate care that go to the ER, call 911, and a mental status exam. Also, the back of the form has physician's diagnosis and orders. So, when in doubt, sit them out. So here is part one, filled out by the coach, which includes evaluation of physical signs and symptoms of a suspected head injury and when to seek immediate medical attention for the following signs and symptoms. If you suspect a head injury and remove the student from play, if you see a significant hit fall mechanism of injury, or you see a sign that the student may be concussed or student reports a symptom of a head injury, make sure the student is out of harm's way. This part is also filled out by the coach, and this is your mental status evaluation. It also includes a signature of staff member who completed the above checklist and a signature of staff member who notifies student's guardian. And remember, only trained Nevada Joint Union High School District staff may complete the form. Student athletic trainers may not complete it. So here is a head injury evaluation form communication flow. 1, suspected head injury. 2, coach immediately completes a head injury evaluation form and gives to parent at time of injury. 3, coach tells parent the healthcare provider must complete the backside of the form. 4, athlete is seen by the physician who completes the form. 5, athlete returns form to the school health office. 6, nurse's office informs coach of diagnosis. And remember, this form saves the athlete's family time and money. So here is a breakdown of the return to play. Per Ed Code, athletes currently in season must complete the NJU HSD head injury protocol, including the return to play steps, or they can receive clearance from their healthcare provider stating that the athlete has completed a graduated return to play protocol of no less than 7 days and may return to full participation in the sports. So this is not the coach's responsibility to go through the return to play. This is just an overview. So coaches are aware of what their athletes are being asked to do. This part is mandated by Ed Code, and it mandates a minimum 7-day graduated return to play protocol that is monitored by a trained healthcare professional. So here are the return to play steps for the student. Step 0 is complete physical rest, no physical activity. The student must stay on step 0 until they have 2 consecutive days of no symptoms. This includes cognitive symptoms as well as physical. Step 1, when they have been symptom free, they can do low levels of physical activity for 15 minutes in duration. This includes walking, swimming, light jogging, and light stationary bike. There's no resistance training weights, no head impact activities, no contact, no balls or rackets. Step two is moderate levels of physical activity, moderate jogging, brief running, and non-complex moderate intensity sport specific drills. No resistant training weights, no head impact activities, no contact, no balls or rackets. And then step three is heavy non-contact physical activity, sprinting, running, high intensity stationary bike, and progression to more complex sports specific training drill. May start progressive resistance training weights, no contact still, no balls, rackets, discs, or clubs. And then upon completion of step three, students must bring back a signed physician clearance form to the health office before participating and practicing and moving on to step four. So step four is full contact and controlled practice, and step five is full contact and gameplay. So during summer months, the protocol is altered due to no nurses office support. If running practices or a clinic during the summer months, you will need to meet with the school nurse to get specific instructions in a summer head injury binder. Summer is the only exception to everything going through the nurse's office. A medical provider will have to follow the students during the return to play and keep all medical notes in the binder to return to nurse in August. And thanks for listening to this presentation. If you have any questions, let the nurse's office know. And there will be a quick quiz after this for you to complete. Once again, thanks so much.